You're all very welcome to the Association of Physicians regular webinar series. The Association of Physicians of Great Britain and Ireland is the leading medical academic society in these islands, and we hold regular webinars because one of our core remits is medical education, and these are monthly webinars. And as you're aware, this webinar this afternoon is on the long COVID syndrome. We have two eminent speakers who will discuss patient stratification and the disability that is long COVID. And we'll also have a state-of-the-art speaker on current trials and therapies and potential future therapies in the context of the long COVID syndrome. In relation to, after the two speakers, we'll revert to a Q&A session. And in the context of you, the viewers, if you could type into the Q&A button at the bottom of your screen any relevant questions that you have, and then Charlotte Summers who will be co-chairing and will coordinate the Q&A session second half of this webinar. Our two eminent speakers, the first speaker will be Dr. Anuradha Subramanian, and she's from the University of Birmingham, specifically from the Institute of Applied Health and Research. And she and her colleagues are at the forefront of stratifying patient stratification in relation to prognosis in the long COVID syndrome, and ultimately guiding future therapies in the long COVID syndrome. And the second speaker will be Professor Charlotte Summers. And Charlotte is Professor of Intensive Care Medicine at the University of Cambridge. She's also Director of the Clinical Academic Training Programme at the University of Cambridge. And she's going to be talking in the context of therapies currently and future to improve the disease that is the long COVID syndrome. So without further ado, I'd like to welcome our first speaker, Anuradha Subramanian. Anu, you're very welcome. And if you'd like to take up the screen and load up your presentation.
Thank you. Thank you very much, Professor Shamus. Good evening, everyone. So I'm Anuradha Subramanian. Thank you so much for the introduction from Institute of Applied Health Research, University of Birmingham. And I'm here today to discuss the key findings from the Therapies for Long COVID, or the TLC study funded by NIHR. I will be presenting today the findings from a large-scale observational study in specific that I was a lead author on, exploring the symptoms and risk factors for long COVID, especially among non-hospitalized adults. The primary aim of the study was to assess the association between confirmed SARS-CoV-2 infection and a comprehensive range of symptoms from various domains reported by patients to the primary care physicians in the acute, ongoing, and long-term or post-COVID-19 phase. We also then went on to assess the risk factors for persistent symptoms post-COVID-19. Finally, we explored how the symptoms cluster together to explore latent clinical phenotypes of this heterogeneous long COVID condition. We also then characterized patients who belonged to different symptom-based long COVID phenotypes. So for this, we undertook a retrospective matched cohort study between 31st of January 2020 and 15th of April 2021, using data from a large UK primary care-based electronic health records called CPRD ORUM. The infected cohort was defined as patients with a coded diagnosis for COVID-19 within their primary care records, without a record of hospitalization within 28 days of infection. For each infected patient, we then went on to obtain a pool of eligible uninfected patients without a record of suspected or confirmed COVID-19. Each infected patient was then propensity score matched with up to 4 uninfected patients using a logistic regression model, including a comprehensive range of covariates like age, sex, BMI, socioeconomic deprivation, smoking status, ethnicity, and a wide range of comorbidities and even symptoms that were recorded 12 months prior to the index date, that is at baseline. A total of over 400,000 non-hospitalized individuals with SARS-CoV-2 infection were identified, and they were propensity score matched with up to 1.9 million uninfected patients. Kernel density plot on the right-hand side of the propensity scores for the infected and the uninfected cohort before and after matching suggests that the two cohorts were actually well balanced post-propensity score matching. In terms of the symptom outcomes, a symptom burden questionnaire for long COVID was developed following review of existing patient-reported outcome measures when the existing symptom coverage was actually insufficient at the moment. Following the conceptual framework and rash analysis, a final set of 115 symptoms spanning 15 domains were identified and were explored in this retrospective cohort study. At 12 weeks after index date, 62 of the 115 symptoms were significantly associated with COVID-19 in the longer term. Notably, these 62 symptoms spanned across 14 different domains, ranging from fatigue, pain, respiratory, mental health, cardiovascular, gastrointestinal, and sexual health symptom domains. The word cloud here sort of represents these symptoms, and the font size within these word cloud is proportional to the strength of their association with the history of exposure to SARS-CoV-2 infection. Loss of smell, hair loss, sneezing, loss of libido, shortness of breath, and fatigue were some of the symptoms that were relatively reported more commonly in the longer term among patients exposed to SARS-CoV-2 compared to uninfected patients. We also considered two composite outcomes, the first one being the reporting of any one of the symptoms that were acknowledged in the WHO definition for long COVID. And the second outcome was defined post-hoc as at least one of the 62 significantly associated symptoms that were reported in the long term. Both of them were significantly associated with COVID-19, and they were reported at 26% and 29% increased hazard at an increased rate among patients exposed to SARS-CoV-2. In the risk factor analysis, we found patients at a younger age, women, patients from Black, Asian, and other ethnic minority background, patients who were socioeconomically deprived, patients with high BMI, and patients with a pre-existing comorbidity were at a higher risk of reporting symptoms that were persistent. We performed a latent class analysis among patients who reported persistent symptoms. We found that the three-class model had an optimal fit. The first class constituted 80% of the patients, and this class included patients reporting a broad spectrum of symptoms. Class 2 constituted patients reporting respiratory symptoms specifically, such as cough, shortness of breath, and phlegm production and excess. And finally, class 3 included 14% of the patients who had mental health symptoms such as anxiety and depression, along with insomnia and brain fog. When we characterized these phenotypes compared to patients who did not report any persistent symptoms, patients in all the three classes were more likely to be women, were more likely to be deprived, were more likely to have a smoking history. With respect to age, patients belonging to class 3, that is, patients who were dominated by mental health related symptoms, were more likely to be younger. With respect to ethnicity, patients in class 1, dominated by a broad spectrum of symptoms, were more likely to be from Asian or other ethnic minority group. We were fortunate to have patient partners who were closely involved in the design and dissemination of the study. As next steps, we are working towards exploring the underpinning pathophysiology using biomarkers across the different phenotypes and exploring the incident autoimmune disease risk among patients with a history of COVID-19 exposure, and also the potential economic impact of COVID-19 in the longer term. Thank you all so much for listening, and I'm very happy to take on questions at the end. I'll now pass this to Professor Charlotte Summers. Thank you.
Thank you very much, Anu. And yes, Professor Charlotte Summers will be our next speaker. So Charlotte, if you want to load up your talk, thank you.
Thank you, Jane.
Just to remind individuals that the questions are through the Q&A button at the bottom of your screen. Thank you.
So I'm going to briefly cover finding therapies to improve longer-term outcomes from COVID-19. The illness itself has sort of three distinct phases, and just to be clear about the bit I'm talking about, there's a pre-acute phase, the acute illness itself, and then a post-acute phase, which can be for some people very short, but for many people actually it's very prolonged. And the different bits of the immune system and the host pathogen interaction are probably pay more or less importance at different stages. Initially, antiviral responses are probably the key thing that's happening, but later on in the disease course, the host immune response also becomes particularly important. There are three things that can happen to you if you have an acute COVID infection. Essentially, you can fully recover, you can get persistently ill, and you cannot recover or become ill because you've died. Now, it's slightly more complicated than that, because actually we know that the acute illness can happen in the community, it can happen to people that are hospitalized, and it can happen to people that are actually so sick they need to be in an intensive care unit. And for all of those people, actually they can go on to have what we know as long COVID, or they can get better. And for the ICU people, they can also develop what we've known for many years to be persistent critical illness. That's probably a consequence of some of the things that we do to you in intensive care alongside having been sick. You know, being in the community and being hospitalized both have a consequence that you may have persistent symptoms and not fully recover from your illness. For the hospitalized patients from wave 1, we've got some really clear data as to what happens. So about 30% of them were readmitted to hospital, 12.5% of them died, and 58% of them survived and weren't readmitted, and all of these were in a median of about 140 days after their discharge from hospital. We had a look at that in terms of the FOST-COVID, which is a national observational study in the UK, which has looked at people who survived hospital and who've come back to some research clinic assessments at a median of about 5 months after their initial hospital discharge. And what they found is that 29% of people said they felt fully recovered, 20% had a new disability, and 19% of them had had a health-related change in occupation. Now, this is data just on a hospitalised cohort. The data will be slightly different for a community cohort, and I'm not sure that we've got as good a data as we should have at this stage in the pandemic. But there is a significant burden of health-related changes in occupation and ongoing disability in people who have community infection who were never hospitalised too. The kind of pathologies that are being identified alongside the symptoms that Anu talked about, actually there are well and increasingly recognised organ dysfunctions and diseases that are clearly documented. People are reporting neurological diseases and issues with motor, sensory, autonomic nervous systems, as well as cognitive and psychiatric impairments. Cardiovascular illnesses, so arterial and venous thromboses, have been well reported, but there's clearly an increased risk of bleeding, particularly early on, that's been reported in multiple studies now. Respiratory, we're seeing persistent respiratory inflammation, as well as the cough, and in a proportion of patients, fibrosis. There's also increased incidence of new diagnoses of things like diabetes. And one of the things that's common for some other severe infections, but definitely being seen in increasing frequency, is an increased risk of subsequent infections, both with SARS-CoV-2 and other sources of infection. So how do we find therapies? Well, I went looking at clinicaltrials.gov to see what trials are there that are registered, that are in clinicaltrials.gov, that have completed and reported results. This is the sum total of trials that have documented in clinicaltrials.gov this morning as being completed that were drug studies, so looking for therapies to improve long COVID. And you will see that actually results are available from one study of sodium pyruvate nasal spray, which is a very short-term phase 2 study of 22 participants. One study was withdrawn before enrolling anyone, so fluoxamine. And the others were a mixture of drugs and dietary supplements. And in the main, all of them, apart from the probiotic study, were incredibly small studies. And results are not available for almost any of them, which is somewhat disappointing at this point. Currently, these are the open studies that I could find listed in clinicaltrials.gov of interventions. So again, quite a few of them are of dietary supplements alongside those of drugs. So there's vitamin D, there's lithium, there's some other sort of interventions that are for inhaled therapies that might help the upper airways. There's a variety of drugs aimed at either immunomodulation or at some of the vascular inflammation, such as atorvastatin, and some of them around antivirals, because there's some Paxlovid longer term studies coming up too. But I think, again, the studies are predominantly small, often single centre, not of an appropriate size that we will ever get out of them evidence of efficacy. So I wanted to highlight two particular studies. One I've got a conflict of interest in because I, along with Mark Toshner and the chief investigator, and this is a study that's UK-wide to try and find therapies to stop people who were hospitalised initially with their COVID coming back into hospital or dying in the 1 year after their index admission. So we're recruiting hospitalised adults who approach the end of their admission to hospital. We're using drug therapies that were selected by an independent expert panel in comparison with usual care, and the outcome is hospital-free survival at 12 months. We're also collecting a range of secondary endpoints, including patient-reported outcomes, so we can understand how people's recovery journey is going and their health-reported quality of life. So we're recruiting people, as I say, at the time they're ready to leave hospital, and we've been randomising them to usual care, to apixaban for 2 weeks. Now, just to be clear, this is 2 weeks from the discharge of hospital. So actually, the majority of people have been in hospital or have had 12 days from their point of COVID positivity to leaving hospital. So actually, they're getting anticoagulated over most of the first 4 weeks, which is the highest incidence of venous and arterial thromboses in hospitalised people with COVID, or atorvastatin, and then we've got room for potential new therapies. For each arm, when there's 181 primary events, there's an interim analysis, and the apixaban arm was stopped at the interim analysis, and it was stopped because actually when we had 402 people who got apixaban and 399 who got usual care, there was no change in the incidence or the rate of death and rehospitalization over 12 months. But I think the stark finding from this is that despite everything we have done to improve outcomes for acute disease in the course of the pandemic, the chances of dying and being rehospitalized in your 12 months after a COVID admission remain 30%. In terms of did we prevent any thromboembolic events? Well, yes, there were thromboembolic events that occurred in not in the apixaban arm that were in the control arm. However, we had 3 cases which exactly balanced the thromboembolic events of clinically significant bleeding during the 2-week therapy with apixaban. So for the PEs and thromboembolisms we may have prevented, we also caused some bleeds. So it probably, the IDSMC and the TSE felt that actually there was no benefit in this therapy. Now, this is to prevent getting disease rather than treatment. So this is not for people with long COVID. This is for people who have been sick with acute COVID to try and stop them getting longer term consequences. There is a big national study in the UK called Stimulate ICP, which is looking at adults with persistent signs and symptoms that they've got to have had for 4 weeks in their post-COVID period, and who are presenting at their first referral visit to a long COVID clinic. They are looking at giving these people 3 months of either loratadine or formotidine, the antihistamines, colchicine, rivaroxaban, the anticoagulant, or usual care. And they're using a primary outcome of fatigue measured using the fatigue scale at baseline 12 weeks and 24 weeks. And so far, when I looked this morning on the NIHR dashboard, they've randomized 373 people from 6 sites, and they're aiming to recruit 4,520, give or take, participants into the drug part of this study, which means it will be of a scale that actually we will get answers as to whether these therapies are efficacious or not in COVID. So I guess in summary, the long-term consequences of SARS-CoV-2 infection are now very well recognised and documented. There's a significant burden of disease and adverse health impacts for many people who've experienced COVID, and we are not doing enough if that's the entirety of the drug studies that we have. There is an awful lot more that we need to be doing.
Thank you very much, Charlotte. So again, we'll look at the Q&A chat box. And we'll bring up your questions, and I'll pass the baton to Charlotte now.
So I think the first question that we probably ought to address is one from Margaret Harris, who says that none of the studies currently ongoing for new drug therapies is large enough to give definitive answers on effectiveness. When and how is that going to change? But I think that's an absolutely important question from Margaret. I think Stimulate ICP, as I hope I explained at the end of that talk, is of a scale that it should be able to provide definitive answers about those drug therapies. And I think in terms of preventing you getting long COVID consequences, Heal COVID was of a scale for the apixaban arm and the other therapies we're doing that we will have some answers. But as with many diseases, the scale of clinical trials that are being done are much smaller than they should be. We do a lot of small suboptimal clinical trials, and that needs to change. We manage that for acute COVID with things like recovery and some of the other big worldwide trials, but we haven't managed to do it quite so well for post-acute COVID yet. Anu, have you got any?
No, I just second your thoughts.
Seamus?
No, I totally agree. But to be fair to the UK, they pre-COVID, with the bringing together of national resources, the UK Biobank, they have got their act together. So the UK as a testing ground offers the opportunity to do it properly. But unfortunately, as you highlighted in the clinical trial, the current clinical trials that are out there, the majority of them are not of sufficient size to address that important question.
So I think Francis Conti Ramson has said, do we have data on secondary outcomes in the apixaban versus controls in relation to symptoms more related to long COVID in HEAL? Yes, we do. We've got a range of patient reported outcomes, many of which are very similar to the data that was collected as part of TLC. Melanie Calvert, who's one of the key investigators for TLC, is also part of the HEAL team. So we've tried very hard to make sure that lots of the data that we're collecting aligns across both of those studies so that we can understand people's journeys. Then there's a question from Professor J. Kennedy Cruikshank for Anu, who says, your data only go to 12 weeks, is that right? And if longer is possible, how reliable are the data?
So it goes beyond 12 weeks indeed. So the analysis starts from 12 weeks post COVID-19 and then any data after that. So the median follow-up was roughly a couple of weeks after 12 weeks from the COVID-19 diagnosis date. But in terms of how reliable the data is, well, it is purely based on coded information within primary care records. But there have been studies that have also looked at records that have been entered into texts instead of just coded information. And these have been analyzed using natural language processing, and they seem to show very similar results. So what we can't say clearly within our analysis is how prevalent the symptoms are, but how relatively higher the symptoms are being reported in patients with COVID-19, that we can certainly establish within the analysis we have.
And then somebody else has asked, Anu, do the 3 long COVID symptom clusters suggest any specific underlying pathophysiology?
That's again interesting because after this study was published, we were interested in looking at the biomarkers and also we calculated pheno age, that is biological age of the patients belonging to these three different classes, and we specifically observed that patients belonging to class 2, which is patients in respiratory cluster, to show specifically abnormal biomarkers to some degree, for example, higher C-reactive protein, higher CRP, and they seem to have higher fasting glucose, and they seem to have abnormal renal function. So there are differences, especially among patients who belong to the respiratory class, and they seem to be also aging slightly faster. But this is based on very preliminary results that we were able to do using primary care recorded information on biomarkers.
Brilliant, thank you. So Ondine Sherwood has said, it's very disappointing that studies in antivirals are not taking place in the UK, especially given the increasing evidence that symptoms in some way may be driven by residual virus. Any thoughts? Seamus, do you want to?
Yes, so what we do know is that treating with antivirals in the acute phase in hospitalized patients, and there are two trials, remdesivir and another trial, does show a 25% to 30% reduction in the prevalence and the risk of catching or getting long COVID syndrome. We do know that it's proportional to virion load. The more viruses or virus particles you're exposed to, the greater your chances of or risk of getting long COVID syndrome. We do know there is a trial going on in the NIH in the United States in relation to the oral antiviral Paxlovid treated in the first 5 days of symptoms of acute COVID with regard to looking at the risk of long COVID. So we do know then there is several good quality research done to show that treating early with antivirals reduces the risk of long COVID.
And that there was, when I looked in clinicaltrials.gov, there is one study in the United States and one, I think, in South America that was looking at antivirals for treating people with long COVID to try and see whether there was viral persistence and whether that made a difference to symptoms and outcomes. In the UK, I couldn't find any study that was specifically using antiviral therapies at the moment in the post-acute phase of the illness. Why do I think that is? I guess people have had to start somewhere with a study, and early on lots of the pathology that people were exhibiting was thought to probably be cardiopulmonary, and so lots of the drug targeting went there because there were obvious therapies that people could use in terms of anticoagulants and in terms of things to address the inflammation. I think the idea of viral persistence has developed a little bit later, and certainly with the data that's come out around Epstein-Barr virus and MS becomes, I suspect, even more plausible. And those studies, I'm sure, should happen, but just I couldn't find that they were at the moment.
So can I just come in there as well, while we're talking about antivirals? You know, it's getting a lot of press, and there were a lot of two modest studies in the context of oral antivirals in the acute phases, increasing your chances of getting a secondary rebound COVID infection. So there's a paper in the current issue of Lancet Infectious Diseases from Hong Kong with a significant number of, from memory, I think 4,500 to 5,000 patients, where they show definitively that that is not the case. So the oral antiviral they were using was Paxlovid, and it was not, you didn't increase your chances or susceptibility of getting a rebound, acute COVID infection second time round.
So I think we've probably just answered some of Margaret Harris's question, which was, given the emerging evidence that early treatment with antivirals reduces the chances of long COVID, is there any chance the UK will expand access to antivirals beyond the narrow cohort of people at high risk of acute complications? We've talked about some of that, but maybe I guess the other part of that is that the most recent data in the UK in a highly vaccinated patients with molnupiravir showed that actually it didn't have an added benefit in terms of preventing hospitalization and those symptoms. I think that's from the panoramic study. In terms of longer term outcomes, I don't think we know yet, but the initial antiviral studies for both Paxlovid and molnupiravir were done in the United States in high risk for death and hospitalization, people who were not vaccinated. And so I think actually the findings in people who are vaccinated are very different to those who have not been exposed and were at high risk. So I think there's differences between the UK and the US populations. But the Paxlovid data I haven't seen, so I don't know what that's doing in our highly vaccinated population. Somebody said, if there are some therapies that are proving to be getting good results in the Stimulate study and trials may be limited in number and more participants need to come forwards, is there a potential to trial within the community in region-specific areas to keep it controlled? I'm not sure that I understand quite what that was asking. Stimulate ICP is still at the very early stages. They've just randomized with just over 300 participants of the 4,500 there or thereabouts that they need. So it's still a little bit early to know whether they're getting results that are going to be translatable or that might work. But I'm sure that they're keen to continue their work, and they're open currently at 6 centres, but have got a call out for more centres to join their trial. So hopefully that is what will be happening over time. Like lots of the other UK studies, a kind of national single study to try and get as many people in so we get answers as fast as possible is the approach that's been taken there. Then somebody has said, are immunosuppressive patients more prone to long COVID? Anu.
So while we didn't quite assess patients on immunosuppressants, we did find that some of the patients who are more likely to be on immunosuppressants, for example, patients with multiple sclerosis and patients with rheumatoid arthritis, they were at a high risk of reporting persistent symptoms in the long term, which may indicate that, yes, patients who are immunosuppressive may be more likely to be at a higher risk of long COVID. Seamus,
you look like you were going to say something.
It's just in the context of rebound secondary COVID, that trial in Hong Kong suggested that community steroids in acute stages for mild disease was associated with an enhanced risk of getting a secondary COVID a few weeks later.
Okay. Then Sydney Van Gelder has said, when can we expect some form of testing with relevant biomarkers for long COVID patients? It would help a great deal to counter those that have the tendency to label long COVID as psychosomatic. Anu, maybe you want to pick up on that.
Well, we are definitely hoping to do that within TLC study. I mean, TLC study is actually coming to an end very soon, but we are very eager to take this forward as much as possible. So perhaps to provide blood spots and get some biomarker estimates from patients with long COVID. And yes, definitely the primary aim here is to remove that term psychosomatic, which can be quite difficult for some people with long COVID.
Yeah, I think I might be even more strident than that and say it's more than difficult, it's just plain wrong.
Absolutely.
We appear to have lost Seamus, so I will keep going and see how we get on with some more of these questions. Beth has asked, is there any evidence to show that if long COVID persists for more than 12 months, that the possibility of recovery is significantly reduced?
That's an interesting question. So far, we've not been able to do that, because to answer a question like this, we would need what's called a time series data. That is, someone to report every single month or every single day, whether they are experiencing symptoms or not. We don't have that yet, but we have been trying to collect patient-reported outcome measures, where we are kind of routinely collecting symptom measures at various time points. We have collected data, and the data collection is sort of coming to an end now. Now I can definitely take this question back and make sure we analyze this, we answer this question in the future.
Brilliant. See, webinar informing research answers being delivered in real time. More of that, I think. So Janice has asked, for recruitment purposes, a lot of data was and is uncoded for COVID-19. So I'm interested in which symptoms were chosen from free text in general practice data.
So in our study, none of the symptoms were actually obtained from free text, because free text is not actually readily available in large primary care databases, just because it makes identification more likely. However, some data sets do provide text data, and it just, rather than saying that certain symptoms are specifically obtained from text data, text data can just be considered as a means to improve the capture. So in addition to coded data, text data can be used. However, coded data would be gold standard, I believe. And
so moving on a little bit from in terms of data and data sources, Sarah has pointed out there are a lot of patients who reported on the Zoe app daily for months and continue to complete monthly questionnaires. So are those data available for review and to inform what's happening?
I'm not entirely sure about that. However, we've been collecting data as well, using the Apparito or Actum5 app. I presume it's fairly similar as well. We're trying to collect a comprehensive range of symptom data, quality of life measures, and EQ5D and things like that. So yeah, that's available for analysis.
So several people, just to kind of pick up on a couple of questions that people have asked around, do you have any thoughts on post-acute COVID symptoms in children? And then somebody else has said, what about disabled children who've ended up with long COVID? Are they being taken seriously or researched? So within the TLT work, were there children or was it all restricted to being older adults?
So far, it's been restricted to adults. That's definitely unfortunate. Thinking, yeah, that's definitely. It seems such a crucial thing that we have to definitely include children into the analysis very soon.
I think that's something that's been a theme across COVID research, actually. It's very clear that there are children who have been considerably impacted and harmed by having SARS-CoV-2 infection, who have got long-term disease.
Yeah, just the routine background thought of, COVID-19 is not that prevalent among children has just basically led to significant exclusion, which is completely wrong. So research is definitely needed to explore this among children.
And I think children-specific research is probably important too. We know very clearly in the acute illness that they were exhibiting COVID syndromes that were not seen in older adults. The PIMS inflammatory syndrome was not something we saw in older adults in the same way at all. So actually they may be impacted in a whole different way. So putting them just into studies designed for adults probably isn't the option. They need dedicated research for children.
Yeah.
Right, looking at a few more questions. So Sarah Kane has said there's a QMU Covidence UK survey also. Are you collating the data from that?
I am unaware of that. How about you, Charlotte?
Because it's outside of my drug sort of interest, so I don't know. I haven't seen the data and not able to access it, but I'm not working on symptomatology, so it isn't a data set that I would necessarily have gone looking for. But I guess with TLT that may be something that would align.
Yeah.
And then Sarah's also said, as a very early sufferer who was clearly had COVID in March 2020, who wasn't hospitalized but went on to have long COVID symptoms for many months, some of which are ongoing. Interested to know if there's any studies recruiting that cohort, or are we too far beyond the acute illness to be participating in any useful work? So there is a study starting soon that's come out of I think it's probably just started actually, the FOSP COVID observational platform had identified people who were 12 months plus and still had inflammation and inflammatory symptoms and some biomarkers, and we're trying immunomodulatory therapies. So I think there are studies starting and developing for people who are months down the line from their COVID infection. So I think there's not enough, as I hope I made clear when I was looking at the therapy landscape, but I think that there's definitely something starting. So I would never say that anybody is outside of research. We need to be making sure that there are things to try and target making everybody better. I don't know if you know of any other studies, Annie.
Well, TLC have just finished recruitment, unfortunately. But we were opening it up to the wider population, and we were just recruiting based on social media and things like that. So
then there is somebody else who said, first question, what is the likelihood of developing long COVID symptoms after each COVID infection? So I think they're asking, does it go up? Does it go down? Does it stay the same?
That's another interesting question. That's definitely, yeah, analysis for that is definitely worth doing within primary care records, because we can certainly identify multiple infections if they had one or two or more infection. However, I've not really done any analysis on that, and I'm not aware of any other study on that as well.
And then the other question was, if treatment options are poor for long COVID, should we be paying more attention to the prevention of COVID infections? I guess I might pick up on that and say, yes, of course, we should be doing what we can to prevent COVID infections. It's not just because long COVID treatment options are poor, but because actually there are no diseases pretty much of any infectious type for which treatment is 100% successful. And all of the therapies have, whilst they've improved outcomes from the acute illness, actually preventing anyone getting sick in the first place and being exposed and infected is absolutely the priority, because there's risk from the acute and the longer term consequences of the infection. So prevention should be the first line of defense for all infectious diseases, I would argue. I don't know if you've got a view on that, Annie.
Absolutely, I mean, most certainly.
Okay, I'm trying to juggle reading and talking at the same time, which is more or less challenging. Right, Helen has said, in REACT long COVID study, we do seem to be seeing lower risk of persistent symptoms in people who had COVID more recently after controlling for vaccination, but we will soon report on recovery. It seems to be slow after 3 months, but we're analysing rates. And so I think that's something that is a source of interest and concern across all of the various different researches. Have the different strains or variants of COVID that have occurred over the different waves, are they having a different burden of outcomes? Is it what we're seeing changing? In many ways, I'd hoped, looking at the hospitalized data for HEAL COVID as an example, when we had no vaccines and no acute treatments, actually 30% of people there or thereabouts got readmitted to hospital after their index admission. I hoped that that would have changed. We started HEAL COVID around about the time just before the Delta and Omicron waves, and unfortunately we're still seeing 30% of people get readmitted to hospital. So we haven't managed to change that. Mortality has come down in the acute phase significantly, but we haven't really changed the chances of you going back into hospital. And I wonder, with the various different other elements of the disease, the chances of different types of symptoms, because we know the acute presentation symptoms have changed too, probably related to the virus altering its affinity for different bits of the airway, for example, whether we're seeing different patterns over time. I don't know if you've managed to pick up any of that in the TLC.
So we did some kind of a subgroup analysis, just exploring the incident rates of symptom presentation in the long term in wave 1 and wave 2 separately, and we did see a relatively lower presentation of some of the symptoms in the second wave. However, it still persists. There was still a high risk among patients who were exposed to SARS-CoV-2, but it was reduced marginally in wave 2. However, it cannot complete. We didn't have any record of the strains that they were exposed to, so we don't have any records of that. Just based on extrapolation from the wave, from the time period that we analyzed, yeah, we believe that in wave 2, the symptoms reported were slightly lower than wave 1.
Brilliant. Alistair Ralsthorne has raised a very important point, I think, and said that if so many research trials are too underpowered to give significant results, is there an argument for funding fewer but larger trials? Is there a role for patient-led research in sharpening research priorities? So I think absolutely the approach particularly in the UK during the pandemic, has been to have national priority studies. Hence, they selected Stimulate ICP, for example, as being the national long COVID platform trial, to try and ensure that we had one big trial that would deliver some results in the same way that we did for the recovery trial for acute COVID and some of the vaccine studies, to try and overcome the problem where we have lots of small studies that aren't helpful. And then, is there a role for patient-led research in sharpening research priorities? I think patients are absolutely critical to research. And I know particularly with Stimulate ICP and with TLC, that actually patients are core members of those research teams, as they are in Heal COVID, and have been involved in pretty much every stage of the study. Certainly I know more about TLC than Stimulate. And maybe Anna, you want to explain the role of participants?
Yeah, absolutely. So in the development of symptom burden questionnaire for long COVID, it was patients who came up with a wide range of symptoms that they experienced. And even within the observational study, patient partners were involved in the design, in the review of the manuscript, in the dissemination. So I would say patient involvement from the start to the end of the TLC study was very strong, and it was in the core of the TLC study.
Similarly for Heal COVID, actually patient participants and partners and wider public were involved from the moment we started thinking about the study. The actual endpoint for the study was changed as a result of advocacy by our patient partners. The regulators initially thought that mortality was the endpoint that was appropriate for a drug trial, and that we shouldn't have anything else, whereas our patient partners and participants that we were speaking to were absolutely adamant that for them, going back into hospital, having been in hospital once, was as important, if not more so, than whether they survived or not. That the burden of hospitalization and the impact that had for them and their families and on their economics was absolutely important. And without that patient voice, we would not have been able to advocate successfully to deliver an endpoint that they thought was more important with the regulators. And similarly, in terms of pretty much everything else about the trial, from our sheets to the languages we deliver the trial in, to how we communicate the results, the thank you messages that we send in the apps, everything is co-designed with our patient partners. And I think that's been one of the better things about trying to do this sort of work. But I'm aware that patients have not been involved at all stages. I think one of the failures earlier in the pandemic in COVID research is that people argued it was too fast, there just wasn't enough time to have the patient voice. And I think that there's probably no excuse for that, and that actually we need to get better, and that patient priorities should be shaping what we're spending our research money on for COVID as much as anything else, actually. Somebody else has said, with the 3 COVID symptom clusters, were there any symptoms that stood out as being more frequent? I missed the earlier slide. So could you just recap that for us, Annie? Thank you.
So the 3 symptom clusters, the first one was the most prominent, but it was the broad spectrum symptom cluster. So there's a problem with the cluster analysis that if you have bigger data, you would be able to, if you have larger amount of data, we would probably come up with more granular symptom clusters. So you could get more and more granular with the data we have. But the most prevalent cluster we observed was the broad spectrum symptom cluster, where people had a wide range of symptoms that were not prominent. And the second most common cluster was the mental health cluster, which was roughly 40% of the patients, where all of them had either anxiety or depression, along with some degree of insomnia and cognitive health problems. And the third one was respiratory symptom cluster, where people had cough, shortness of breath, and phlegm production. And that was roughly 8% of the patients.
Brilliant, thank you. Then Sydney Van Gela has said, is there a known link between long COVID and changes in the stability of heart rate variability, possibly causing fatigue? And if so, is there a way to improve heart rate variability other than with less exercise, with exercise, less stress, and good sleep?
That's an interesting question. So some of the symptoms were related to heart rate variability indeed. But I don't know if that is the mediating factor between SARS-CoV-2 infection and fatigue. So that's one way to think of it, definitely. So that's potentially something we could explore as well. But in terms of improvement, I'm not entirely sure. Do you have any comments?
So there's definitely people who are reporting symptoms where they do have profound tachycardias, and that mildest bits of exercise are actually leading to them to have really quite marked tachycardia that they wouldn't have had before having been sick, that is persistent. So I think heart rate variability changes are definitely being noticed in people with long COVID. Do we know the ideal way to treat them? I think at the moment we don't. I know Sydney says just exercise, less stress and good sleep might treat them, but actually there's concern about exercise and long COVID, in that there is some concern that actually things like graded exercise may actually make symptoms worse and be harmful in some patients, at least, if not more, with long COVID symptoms. I don't know if you wanted to talk about exercise and symptomatology, if anything came out in TLC about that.
There were discussions around it. So this was one of the comments from the patient partners, that when we were in the process of potentially thinking about BioWares to record their heart variability and measures like that. And when BioWares used to, suggest, oh, it's time to do something or something like that. I mean, that could potentially be a putting off factor. That could cause a little bit of anxiety, and so obviously it's not just about exercise. I believe. I think there should be something more than just exercise when it comes to treatment.
I think there's concern rightly in the participant and public community, both from COVID and actually from the experience from chronic fatigue syndrome and ME, that actually exercise programs have made people get worse and potentially taken them backwards rather than improve things. So I don't think that it's as simple as, here you go, have an exercise program, it'll all be fine. And for large quantities of the pathology that's being existed, actually exercise would do nothing and potentially harm. So I think that actually a tailored, personalized approach for the different symptoms and conditions that an individual patient is developing is what's really important. The spectrum of disease and impact of the SARS-CoV-2 virus, I think we just are only starting to appreciate. I think there'll be lots more. Some people present with very neurological symptoms, with mononeuritis, with all sorts of very focused things. Other people present with persistent cough and develop fibrosis, and I don't think we really understand what it is that make those people different. And within that, what are the appropriate therapies for the people that are in front of us? I think we have so much more to learn about this new virus that we didn't really know about 3.5 years ago.
Yeah, gladly we are now in the process of establishing that this condition is severely heterogeneous, and that we need to target therapies for each phenotype separately, ideally.
So Alistair has said, can I ask you both, what would be your research priorities now if unlimited resources were available? So Annie, do you want to go first?
Well, imagination running wild here. I would be more interested in understanding biomarkers and pathophysiology, because I believe the development of medications should ideally be driven by understanding the pathophysiology and the targets. So understanding the disease condition, I think, is key.
I think actually in this space, if I had an unlimited budget and could do anything, I think developing a learning health system where actually we learn about the mechanisms of disease whilst perturbing the system and trying drugs that we think are most likely to help, very much in the way that some of the cancer field has moved to. The risk is, if we do a lot of observational work and observational biology, during that period of time, people are still being harmed by being exposed to the virus and getting long symptoms. If we randomize, we learn. We may learn that this therapy doesn't work, but that's great. We can move on to something that does. So I think combining biological and mechanistic understanding with trying to find therapies that can transform outcomes, rather than doing that sequentially and doing that in a data-informed way, which is, of course, I've just spent multiple millions of pounds with that proposal, but I think that's what I would do now. So I think I've just been given the warning that actually it's 5 minutes to when we're supposed to close. So I need to say thank you very much to Anu and the TLC team for coming to talk to us today. Thank you to Seamus, who organised this webinar, who unfortunately has had a technical failure and dropped out. And just to say that this is an Association of Physicians webinar, and that for those of you that don't know, the Association of Physicians, as Seamus said, is the leading translational medicine society in the UK, and that we have our annual meeting on the 20th to the 21st of April in Liverpool. So please, it's got a really stellar programme with all kinds of exciting speakers. So please do take a look at that. And they're putting the link to it in the chat so that everybody can see, and do please look out for that and think about registering and coming and join us in Liverpool. Thank you very much. Thank you, Anu.
Thank you.